It's my great pleasure to introduce today Dr. Sandro Galea. Sandro is actually a very old friend of mine, and I can tell you, I'm going to skip from the official introduction just to tell you that he's actually a really nice guy as well as having a whole slew of accomplishments. Not on his bio, but just newly announced is that Sandro in January is going to be the new Dean of the School of Public Health at Boston University. In addition to that, he is currently the Charles Gelman the Anna Cheskis Gelman and Murray Charles Gelman Professor and Chair of the Department of Epidemiology at the Columbia University Mailman School of Public Health. He has a very extensive publication and grant history. His research interests are very broad and include the social production of health of urban populations, innovative cell-to-society approaches to population health, brain disorders, and the consequences of mass trauma and conflicts worldwide, which is somewhat of what he's going to talk about today. And he also told me before this lecture started that he had the title before Naomi Klein did. So, so please welcome Sandro.
Hello, everybody. Thank you, Ahmed, for that very kind, generous introduction. What Ahmed didn't say is that I was a clinical cleric here at U of T, and he was a fellow when we met. So he actually knows all the things I really don't know how to do very well, but he's very kind not to say that. So I am talking about, can you hear me okay? In the back? Yes? Okay. So I'm talking about trauma, which, as Ahmed mentioned, has been a concern of mine for really throughout my academic career. And I wanted to do a bit of an overview of how trauma affects the health of global populations. And I use the title, This Changes Everything, and I do have evidence that's been, I've been using it for a couple of years because I'm going to make the argument that trauma is one of those understudied, under-considered, under-understood social determinants that really changes the health of entire populations. So having said that, let me plunge in. And I will start by saying, as Ahmed introduced in the summary of what I'm interested in, that the reason I'm interested in trauma is because I'm interested in the health of populations. So I'm really interested, at the end of the day, in how we collectively can become better, how we can collectively change the conditions that make populations healthier. Now, the problem with population health is that it becomes a little bit of this abstract term, a little bit miasmatic. So this is my favorite definition of population health, which is ultimately it's the health outcomes of groups of individuals, including the distribution of such outcomes within the group. So I want to briefly tag this notion of intra-group variability in health outcomes, which typically goes by the name of health equity or health equality. I'm not going to touch that much today, but I do want to make it clear that I think that's an integral part of any population health thinking. I am today going to talk principally about how trauma affects the health outcomes of groups of individuals and why it is that that matters. It matters, and the reason that I'm in public health, and the reason that actually I moved to public health from clinical medicine, is because if you're interested in health of populations, it gives you an opportunity to intervene. And in intervening, one can improve the health of thousands of people at a time if one does it right. So that's population health. Now, why trauma? So this is a bit of a perhaps grounding as to why one should care about trauma. The problem with talking about why trauma with this group is that you walked into the door, which means you probably have some interest in the topic. But let me at least give you some framing for how one may think about why trauma matters. So first of all, what is a traumatic event? In the scientific and lay literature, we have a problem with the use of the word trauma. And I tend to tell my students we never use the word trauma, even though it's in the title here. And the reason for it is because in the literature, we tend to conflate the traumatic event with its consequences. And you see the word trauma used to talk about psychopathology, about physical injury, as well as about the incident itself. But for the purpose of this talk, I'm talking about traumatic events, that they are events that can cause physical, emotional, psychological distress or harm, and they are perceived by the individual as a threat to oneself. That's the event. And within that, there's a question of what are these events, which I will get to shortly. This is a very colorful, but not particularly informative graph from the global burden of disease. And the reason I'm showing you this is simply to make a point about a few of these causes, which I underlined on your right. And all I want you to see is that the colors that correspond with what I've underlined really roughly are in the middle of the curve, and they're bigger in the middle of the curve. What this is showing is, on the x-axis, age of populations and where we are losing disability-adjusted life years. And causes like war and disaster, unintentional injuries, transport injuries, mental behavioral disorders, cardiovascular disease, respiratory disease, all disorders or incidents that are linked to trauma and traumatic events, take away most of quality of life in the middle life years. That we're dealing with the chunk of population 15 to late 40s, which is typically the most productive part of lives worldwide. So trauma at a first level is affecting people very much in the prime of life. Now, taking an American lens for a second, this slide looks at the most expensive medical conditions in the US. On the left, you have absolute costs. On the right, you have relative costs. The two match very nicely. But if you just look at the left, and starting from the bottom, you see the most expensive medical conditions in the US are heart conditions, cancer, then trauma-related disorders, then mental disorders. Now, we know very well that most mental disorders are substantially influenced by trauma. So if you add the mental disorders and trauma, that in and of itself gives you the most expensive medical conditions in the US. I'm not familiar with the Canadian data, but I'm sure it's very similar here. And why is that? Well, it's for two reasons. Number one, traumatic events are common, as I'm going to show you in a second, and their consequences linger. So these are chronic conditions. They very much fall in the realm of chronic diseases. The global argument is about including mental disorders, trauma-related disorders in the rubric of non-communicable diseases. They're chronic conditions that are highly prevalent, and that means that they take a large chunk out of the health of populations. If this is a stylized population, these are all people in a particular universe. The red are people who experience some significant traumatic event in their life, which is about 90%. Trauma is one of those conditions that it's a little bit like divorce. We all think it never happens to you, it happens to somebody else. But in fact, it happens to most people. So nearly everybody in this room will experience some significant traumatic event in their life. And in high-risk populations, about 1 in 2 people will experience a trauma in any given year. By high-risk population, these are data from urban samples from in many urban areas. People are experiencing, about 50% are experiencing a traumatic event at least once a year. So it is a highly prevalent condition. Now, complicating trauma and complicating the consequences of traumatic events is the occurrence of large-scale traumatic events. So traumatic events as a determinant of health are unusual in that there is a group-level analog. And that group-level analog we typically call a disaster. So large-scale traumatic events are disasters. The word comes from Latin, which is disastro, which is bad star, which essentially means like something bad happening with unfavorable position on the planets. With echoes, of course, God wanted it to be that way. As I'm going to get to in a second, that is a misconception on the part of the ancient Romans on the causes of disasters. And today, we think of disaster as a potentially traumatic event that's collectively experienced. So something that happens to all of us. Has an acute onset, is time delimited, and can be due to natural, technological, or human causes. There used to be a debate in literature about, well, do traumatic events due to natural causes or to human causes matter more or less? I think that debate is largely settled, that it doesn't really matter what the cause of the traumatic event is. They have similar consequences. This is from the UN database of disasters worldwide, natural disasters, and what you see is that the number of natural disasters have been increasing, which of course would be surprising if we thought of disasters as being bad stars, events caused by God, because then it's like suggests that God is getting more mad at human beings, which may be the case, but let's assume not. Why is it that disasters are increasing? 2 reasons. Number one, urbanization. We are putting more and more people into densely packed urban areas. And number 2, global environmental change. That global environmental change has resulted in large number of hydrological disasters, and many of those disasters affect large, densely populated urban areas. So that's why you see an increase in number of people being affected by large-scale traumatic events. And just to ground home how big these events are, this is a map of Mississippi on your left and Louisiana on your right, and these are the 2 states that were hit by Hurricane Katrina about 10 years ago now. And the orange part were the areas that were declared a federal disaster area. And we all know that Hurricane Katrina was a big event, but I bet that most of us do not realize that the area that was declared a disaster area after Hurricane Katrina is an area the size of the entire United Kingdom. So that puts it a little bit more in scope that we are dealing with conditions that affect large numbers of people in large swaths of land area. And when you look at the most common disasters in the world today, and the ones that affect most people, many of them are in Asia, affecting Chinese cities where you have 35 million people at a time affected by these enormous large-scale events. So these are clearly events that can truly shape the health of populations and that can change everything for large groups of people. From a scientific point of view, one of the challenges with understanding the role that trauma plays is the challenge of ubiquity. Now, this is a classic graph from canonical public health teaching. It's from Jeffrey Rose. It has nothing to do with trauma, but this is just a schematic. If you look at the x-axis and the y-axis, this happens to be about water hardness and standardized mortality rate. You can all look at this graph using the statistically sophisticated method of your eyeball and realize that there is a line that goes sort of that way, right? That the softer the water, the harder the water, the lower the mortality rate. So you look at that. If you were so inclined to get a doctorate in epidemiology, spend a lot of years learning how to analyze that, but ultimately coming to the same conclusion that the further right you are, the lower your standardized mortality rate. Now, supposing I were to cover that part. Now when you look at that, do you see an association? And the answer is no, because now you just see scattered, there's no real line. But you would say, why would I obscure half the graph? Well, it is not unreasonable to obscure half the graph if to the right of the dotted line was England and to the left of the dotted line was Wales. It is not unreasonable to do a study like this only in Wales. And the point of this is to illustrate that when something is ubiquitous, when something is experienced by everybody, in this case, water hardness, well, softer water on the left side of the scale, it is very difficult to see what impact it's having on your outcome, in this case, standardized mortality, because you do not see the bigger picture. And that is exactly the story that we have with large-scale traumatic events. They affect everybody, so we frequently do not notice how they result in a shift of the health of the entire population. The other analogy that I've used before is the goldfish bowl analogy, that we are very much surrounded by these circumstances, and when they change, we frequently don't notice them, much the same way as the goldfish doesn't notice the quality of the water around it, because that's all the goldfish knows. And one last metaphor for this is that without understanding this, many times in clinical medicine, without understanding the potential implications of trauma for the health of individuals that one sees as a clinician, one is frequently left understanding only part of the picture. One is frequently left looking at things like this and wondering what I'm showing you, or if you wandered in a few seconds late, wondering if you missed something. But in fact, the reason you don't know what it is because that is just part of a larger picture. And the larger picture is understanding traumatic events and how they shape the health of populations. And if one is interested in population health, understanding the role that traumatic events play in bringing the health of populations to where they are now. So having said that, how do we then move to understanding the consequence of trauma on populations? So given the fact that we only have 45 minutes, I am focusing here on mental health. One could do a comparable talk around physical health. One could do a talk that combines mental health and physical health. I'm here focusing on mental health consequences of trauma, although, as I said in the beginning, there are many of the other physical health consequences which I could talk about as well. So let me start with a central point, which I don't want to get lost. Although I am here talking about the consequence of traumatic events on the health of populations, broadly speaking, with very few exceptions, most people who are affected by a traumatic event are fine. They have neither psychopathology nor physical pathology. It's a hard point to wrap one's brain around because it seems almost in contradiction with the point that traumatic events affect the health of populations. But it's not in contradiction because populations are much larger than any single majority, and having even a few people in a broad population affected results in hundreds of thousands and millions of people. So schematically, going back to my schema of blue people, populations, if a subset of people, here the red people, are affected by a traumatic event, what we tend to see, that's the black axis, that a subset of those affected directly and those not affected directly will have the health consequence of traumatic events. Meaning higher risk over there among the red people, some risk, lower risk among the blue people, but more blue people than red people, making for a pervasive influence of traumatic events. So now, having said all that, how do we understand the consequences of trauma? So if one says, we're interested in understanding the consequences of trauma, one almost inevitably goes to thinking about the aftermath of trauma. And surely to understand the aftermath of trauma, we should understand the traumatic event and what comes after it. And that is broadly where the field was until about 2000, 2001. What we have understood since is that if we want to understand the consequences of trauma, we need to understand fully the determinants of those consequences over the life course. Schematically, if the blue line is time, going from left to right, one experiences, or a population experiences a traumatic event, that's the black line, and then there are consequences. Now, the consequences come after the traumatic event, but the drivers of those consequences are not only the trauma, but also determinants that precede the trauma. And I'm going to get into this in a second. This, of course, suggests that for us to understand the consequences of traumatic events, we need to understand the trauma itself, what came before it, and increasingly, what came after it. For anybody who's interested in that, and a little bit of shameless self-promotion, we did a book on this called Life Course Approach to Mental Disorders, which really tried to frame for our thinking the notion that mental health is produced across the life course. It starts from perinatal period, through infancy, through adolescence, through adulthood, to old age, and in fact, that there probably are intergenerational elements of transmission of mental disorders, which I'll show you in a second. So having framed that, I'm going to now in the rest of my talk about these two elements. I'm going to talk about the trauma itself, and I'm going to talk about the pre-trauma and to some extent post-trauma drivers of the consequences of those traumatic events. So let me start with the trauma itself, and I'm going to I'm going to use a number of empiric examples, and I'm going to draw on work our group has done, work I've been fortunate to be involved in, as well as in some cases on the work of other groups. I'll start, and I'm going to go very quickly through a number of different traumatic event examples without spending much time on the methods, but I'm happy to talk about those later. Start off with September 11 terrorist attacks in New York City, where we had done a series of studies after the attacks. And these attacks were, which are now receding into the memory of history. But at the time, they were, in many ways, the first terrorist attacks, the first disaster that was experienced live globally. And as a result, had quite an impact both on scholarship in the area, as well as on our understanding of the consequences of trauma. This is a map of Manhattan, and I'm going to show you the black dots are residents of Manhattan that were part of a larger study that we did of the entire tri-state area, which I'll show you in a second. For those of you who have been to New York or haven't been to New York, but you might recognize this, so I don't have a pointer, but you see there's the rectangular space with no black dots in it in the middle. That's Central Park, so it's the park, nobody lives there. You'll also see that people live to the west of the park and to the east of the park, Upper West Side, Upper East Side. You'll see under the park, there's Midtown. That's actually where all the tourists go, so nobody lives there, actually. And then you see people live in the south of New York City, and the people live in the financial district where the World Trade Center was. Now I want to show you a map showing where these people were moving to at 8:46 in the morning on September 11, 2001. So at 8:46 in the morning, these dots had moved that way. So what you now see, Upper West Side, Upper East Side had emptied. People now are in Midtown, and people now are in the financial district. So these events, the terrorist attack of September 11th, were an event where people were moving towards the event. And I could show you this in the broader tri-state area, but it's easier looking at Manhattan. We did studies that involved the entire tri-state area. That's Manhattan in the middle, New York City, Long Island, Southern Connecticut, and Eastern New Jersey. And this is a color density graph of the prevalence of post-traumatic stress after September 11th. Post-traumatic stress is in many respects the sentinel psychopathology after traumatic events. And I want to make 2 points with this graph. Number one is, as you can all see, the colors are darker in the middle, right? You see the darker colors around New York City than there are in, if you go on the right of the map, which is Long Island, or on the north of the map, which is Connecticut. So the first point is the area that is most directly affected by the traumatic event, in this case, the area closest to to World Trade Center, has a higher burden of psychopathology. So number one, the closer you are to the trauma as a population, the more damage the trauma is going to do. The second point, though, if you look carefully at the map of New York City in the middle, you will see that the color on Manhattan, which is sort of the peninsula shape that I showed you earlier, is lighter than it is to the right of it, which is Brooklyn, and to the north of it, which is the Bronx. So within the broader notion that the closer populations are to the trauma, the worse populations are, there are clear exceptions. And there are reasons why both Brooklyn and the Bronx were exceptions. For Brooklyn, which is to the right of Manhattan, is because the way the geography of Manhattan is, the visibility of the World Trade Center is much higher in Brooklyn than it is in the rest of Manhattan. So more people in Brooklyn directly experienced the trauma than the people in Manhattan. While for the Bronx is predominantly Latino. And we have, in this study and in other studies, shown that Latinos are more likely to have post-traumatic stress after trauma than are other ethnic groups. And there are many reasons for that, which I can discuss. So that's a first snapshot. That's New York City. This is 2.5 years after September 11th. This was in Madrid. This is the 2004 March 11th train bombings. It was the largest terrorist attack in Europe ever at the time. It killed about 192 people. And we were able to do a study. It was an unusual study because we were able to assess systematically the mental health of multiple different groups of people. Now, a couple of things about the Madrid train bombings. These were trains in a European city that is actually well designed for public transportation, which means this was nowhere near as visible an event as was the World Trade Center bombing in New York City. So you have a traumatic event where you have less visibility, fewer people directly exposed to the event. And you must understand that when one then looks at what was the burden of pathology after this event. So the burden of pathology after this event comes as follows. This is a bar graph, and going from left to right, this is an assessment of those who were injured in the event, those who were residents of Alcalá. Alcalá is a suburb of Madrid where many of the people who died or were injured came from, which in that sample includes a lot of family members. Police, general residents of Madrid, and a baseline sample from prior study. What you see is that the burden of pathology is highest among those injured. So this is a classic example of the comorbidity of physical health, injury, mental health, post-traumatic stress. Dramatically higher prevalence, and you see this in study after study after study. Those who are most directly affected by the trauma are worse off. Residents of Alcalá, who are the next outer circle, so to speak, of exposure, are second most likely. Then you see the residents of Madrid, which is the fourth bar, are actually quite low, a reflection of the fact that it was a low visibility event. Then there's something interesting here, which is the police. The police are lower than the general residents of Madrid, but in fact, there have been studies that have shown that uniformed personnel that respond to traumatic events have a reasonably high burden of psychopathology. Why were the police low here? The police were low here because it was a selection effect. Because Madrid, unfortunately, has had a series of bombings due to principally to the Basque separatists. And this was a special group of police who had already been selected, who had done fine after previous traumatic events. So there's a selection effect that you're seeing here with police. So this really gets at the burden of the traumatic event exposure. And I want to show you one more graph on the same point. This goes back to September 11th. This is now over time. This is months after September 11th. The x-axis remains the y-axis remains PTSD. And what you see is the trajectory of PTSD over time. It gets a little bit better. There's a dip, and then there's a stabilization over time. The dip we see in many other studies, it probably reflects a honeymoon period after a traumatic event where you have an infusion of resources where everybody cares about the affected population. And then, of course, you get back up when people stop thinking about it. But what I want to show you this for is I'm going to split this line into two. I'm going to split this line into the people who are most directly linked to the event, who are closest to the event, and people who are further away from the event. So if you look at the next graph, I'm going to take this orange line and break it into a red line and a blue line. So the orange line is now the dotted orange line, and the red line are people who are most directly affected, the blue line are people who are less directly affected. What you see is that at every time point, the burden of PTSD remains higher among those most directly affected than it is among those less directly affected. That's red is bigger than blue at all time points. But of course, what I set you up for earlier by showing you my population schema is that in most populations, when large-scale disasters happen, there are more blue people than there are red people. Because even in a disaster as big as New York City in September 11th, you really still had at most a quarter of people who had direct links to the event. So even though there's lower prevalence in the blue line, as a population sheer numbers affected, you end up with more people in that group. But the point here is that at every time point, those who are more directly affected are more likely to have the consequences, suffer the consequences of the traumatic event, those who are less directly affected. And one last point on this, going to a different continent. This is from a country that unfortunately is very much back in the news again. It's from Liberia. It's been in the news because of Ebola, of course. Liberia went through a terrible civil war about 20 years ago. We were able to do a study to document the burden of the civil war in Liberia on mental health. In particular, we looked at Nimba County. Nimba County is on the northeast of Liberia, so Monrovia is to the bottom left. It's right next door to Côte d'Ivoire. And the civil war in Liberia started in Nimba County. So the Charles Taylor and the Lord's Liberation Army entered Liberia from the northeast. And what you see on this map, you see there are circles with numbers in them. Those numbers, if you look at the legend at the bottom right, are actually dates. So these are historical events in the civil war in Nimba County, as Charles Taylor and his men went through, and they came down from Côte d'Ivoire, and then they went down on the road, and they came down here towards Monrovia. And the civil war was raged very violently in Nimba County, but then it stopped, because then the fighting really went down out of Nimba County. So we did a study about 5 years ago. So really this was 20 years after the fighting. And we wanted to assess the burden of psychopathology in this population. So we did a representative sample of villages in Liberia. And the next slide I'm going to show you all the villages that were randomly selected from all the villages in Nimba County. And I'm weighting the villages by the burden of psychopathology. And what you see here is as follows. Is that the burden of psychopathology, perhaps not surprising, very much follows the historical path of the traumatic event experience. Starts this way and sort of goes down this way. The other villages are much smaller. Now, in some respects, this is not surprising, but in other respects, remember, this is a pattern of psychopathology in villages 20 years after the fighting stopped. This includes all adults, some of whom were infants when the fighting happened. And what this is getting at is about the deep, lasting consequences of trauma and the path that trauma can cleave in populations and in population health, which here we happen to see geospatially. Okay, so now we've talked about the trauma. Now I'm going to move to the life course. So accepting that the central driver of the consequence of traumatic events is the traumatic event. Now I want to move systematically through the life course. And I'm going to start early in the life course and move on to later in the life course. And to do that, I'll start with genetics and biology. Around the turn of the 20th century, we began to realize that there are determinants of the consequence of traumatic events that are genetic, that you are born with particular genetic complements that might make you more vulnerable to the consequence of traumatic events. I will say, right at the outset, that unfortunately, that notion has frequently been oversimplified to the point of absurdity into thinking that these are common variants and that I am at risk, yes, no, you're at risk, yes, no. It's not like that at all. These are complex genetic processes that we do not understand anywhere near at all. However, we do understand enough to know that there are particular genetic variants that are associated with greater risk of psychopathology after traumatic events. This is from a study we did, which was a genome-wide association scan. And the red dot, which is over there, this is called the Manhattan plot, is simply showing a functional gene called the RORA gene that we know is associated with with adverse consequences after traumatic events. It is undoubtedly part of a complex set of genetic factors that ultimately produce the phenotypes that we recognize as pathology. More recent science, perhaps more interesting, look not at genetics, but at epigenetics. They look at modifications around the unmodifiable genome, but there are modifications that can change the transcription of particular genes. So in this case, we're looking at methylation, which is on the x-axis, and on the y-axis you have PTSD, and I want to lead you to this graph what it shows. So first of all, what you see is that each of those shapes, so the circle shape is 12, the triangle shape, going from top to bottom, they're 12, 9, 6, 3. And what those are number of traumatic events that people in this study experienced. So the first point I want to make goes back to my point about the centrality of the traumatic event, right? That in all of these curves, those who had 12 traumas were worse than those who had 9, worse than those with 6, worse than those with 3, right? Everybody see that? That's at every one of the curves. But then, the curves show that at different methylation levels, which is different changes in the molecular structure around the DNA, you can have different odds of PTSD. So if you go this way, more methylation, you're going up higher with greater odds of PTSD, and that is intersecting with the number of traumatic events. So what is interesting and exciting about this from a scholarship point of view is that this represents a mechanism through which we can understand how traumatic events get under the skin, that we can understand how traumatic events can result in changes in the molecular structure that might change genetic transcription, that might change the phenotype that we call pathology. And perhaps even more interesting is that we know that a number of these epigenetic changes are heritable. And that might explain why, some of the data I'm going to show you in a second, that there is a heritability, an intergenerational transmission of the risk of post-traumatic stress disorder or the risk of the other consequences of PTSD. So first point, there are genetic and molecular factors that explain how it is that trauma gets under the skin, that trauma becomes manifest as pathology. Second point, pre-event childhood and generations. So this really gives flesh to the maxim that the best way to make sure you're healthy is to choose your parents well. And this really, we can show this in many different ways. I'll start with a very simple graph. This is, as far as I'm concerned, the paradigmatic dose-response curve, which in epidemiology we used to teach our students. All you have here is on the x-axis, number of traumatic events experienced by children, and on the y-axis, likelihood of depression in their, as adults. And what you see is the more traumas that are experienced, the more likely they are to have depression later in life. I will pause here to acknowledge that there used to be some controversy in the literature about this notion of inoculation or kindling. There used to be these theories that said that if you have more traumatic events, you sort of inoculate yourself against future traumatic events. And I'm here to say that I am not convinced there's any evidence for inoculation, that the literature is pretty clear that more traumatic events are worse than fewer traumatic events. And this dose-response relationship you see time and time again. Now, to drive home the point about the centrality of childhood experiences for subsequent adult consequences of traumatic events, I want to show you this graph, which comes from a study that's currently ongoing of soldiers in the US. So these are soldiers, these are young men who the government sends in harm's way, who experience traumatic events as a condition of their employment. And of course, when we think about health among military populations, we almost inevitably think about, well, they have health consequences of the traumatic events they experience. But is that really the picture? So here, what you have is soldiers. On the x-axis, you have number of months after they experience a particular traumatic event. On the y-axis, you have depression symptoms. And using something called latent mixture growth modeling, we are able to look at different types of soldiers. And what you have here is the purple type, and these are people who, after a traumatic event, have a lot of depression symptoms and keep having them forward in time. The green type is the contrast, which is soldiers who really have a traumatic event and have no symptoms ever. And then you have the red type and the blue type. The red type are people who do get better, the blue type are get worse over time. But when you look carefully about who is the purple type and who is the blue type, what you find is that what's distinguishing, whether soldiers, again, these are soldiers, these are people who are all experiencing a traumatic event. What distinguishes the groups are childhood adversity, high number of lifetime stressors, and other lifetime traumatic events, not the event itself. So yes, the event itself has consequences, but the driver of pathology in the long term in populations is as much the life course exposure to the pre-event characteristics and the post-event, as I'm going to show you in a second, as it is the traumatic event itself, seen here very clearly in a cohort of soldiers. So this is part of a paper which is, I can't remember, in press or under review. The point here is that when one thinks of military health, in many respects the field has had a bit of a problem in that almost inevitably, perhaps by the name, we keep thinking of health as linked to the military experience. While it's certainly the case that the military experience is affecting health, it is also certainly the case that the pre-military experience and the post-military experience is affecting the health of those exposed to trauma as much as the trauma itself. This is from another mass traumatic event. This, I don't know if people remember this. This is Haiti in 2009. And this is the Haitian White House. And I don't know if people from the back see this or if you remember this. I always like this picture because it really gets at the point about how Sometimes if you don't look carefully enough, you think, well, everything looks fine, right? It looks like a building, it's standing up fine. Then you look carefully, and you realize that the entire second floor is pancaked and obliterated. Everybody see that? So really the first floor is fine, second floor is obliterated, which is not atypical of earthquakes, and was the case in all over Port-au-Prince. So we did a series of studies in Port-au-Prince after this event, and I want to show you just one slide from this study, which is this one. So ignore the right and the bottom graph. You can just look at the one on the top left. The right, that one is women, this one's men, but the same picture emerges overall. So if you look at the top left, you see two lines. On the y-axis, you have post-traumatic stress disorder. The two lines represent two different types of people. The dotted line are people who, before the Haiti earthquake, had experienced a violent trauma. Now, Port-au-Prince is a very violent city, so it was actually pretty high prevalence of violent trauma. It was like about 50%. The black line, the solid line, are people who had not experienced a violent trauma. On the left are people who were not trapped by rubble. On the right are people who were trapped by rubble. So what you see is that in a group of people who were trapped by rubble, which is a pretty horrible traumatic event. For someone who's a little bit claustrophobic like I am, it strikes me as a fate worse than death in some respects. People who were trapped by rubble did have higher PTSD than those who were not, but only in the dotted line group, in the group that did have prior traumatic event experience. Amongst those who never had a prior trauma, being trapped by rubble had no effect. So this is a pretty stark reminder that the pre-event experiences are as powerful, if not more powerful, as determinants than is the event itself. This now gets at sort of bad news for children everywhere, which is that kids are right, it is all your parents' fault. So this is from a study we're able to use Nurses' Health Study, which is a large study in Boston, which has a sub-study called GUTS, which is the children of the nurses. And what you have here on the x-axis is the number of symptoms of post-traumatic stress that the mom had in her life. So as you go from left to right, these are moms with more post-traumatic stress symptoms. The bars represent number of symptoms the kids had if they had a traumatic event, And the darker the color are the more kids' symptoms. And all I want you to see, as you go from left to right, you see how the kids get more and more in the darker bars? So the kids who are children of moms who themselves had more post-traumatic stress symptoms are more likely to have these symptoms themselves if they experience a traumatic event. Now, why is that? There are many reasons for that. Part of that probably is biological. Part of that probably shared environment. Part of that is probably child rearing. And there are many complicated reasons for that. But it really makes the case nicely that some of the risk we see in populations is pre-programmed and predetermined by adversity experienced by previous generations. I have no doubt that one could show this over many generations if there were such data, which I'm not aware that they exist. Showing the same point, this is a study we did in Ethiopia, an area of conflict. And what you have here is on the x-axis, number of traumatic events. On the y-axis is depression. The dark line is women, dotted line is men. What you see here, more traumatic events, more depression. I've shown you that a million times now. But this is now looking at the development of the children of these moms. And on the x-axis is age of the child. On the y-axis is a score on a developmental scale. It's a Denver developmental scale where you observe the child doing various things. So you see two things. Number one, as the kids get older, their development gets better. Across the board is what you expect, right? But then you look at the white bars and the black bars. The white bars are kids of non-depressed mothers. The black bars are kids of depressed mothers. And you see that at every time point, with the exception of one, there is a statistically significant difference in child development, that the kids of depressed mothers have lower child development than kids of non-depressed mothers. Again, why is that? Probably many reasons for it. It's probably a combination of biological, behavioral, social, cultural, and experiential for the child. So now the event happens. And when a traumatic event happens, either for individuals or for populations, we, as pro-social human beings, pay attention. We tend to think about how we can help. And then, as tends to happen, because we're also human, the event happens a few weeks or months later, we forget all about it. And increasingly, the science is beginning to show that what happens in that post-event period might be as important, if not more important, than the traumatic event itself. And we did not know this, in large part because we are myopic, and our research lens and our public attention focuses on the event itself. This is Hurricane Katrina. Again, everybody here will remember some of these horrific images of people after Hurricane Katrina. And now I want to show you this graph, which is going to involve a study we did in Mississippi after Hurricane Katrina, that involves, I'm going to show you only people who develop PTSD after Hurricane Katrina. So I'm removing those who did not. I'm keeping only those who develop PTSD. And I want you to look at how long it takes for their PTSD symptoms to resolve. So this is time on the x-axis. On the y-axis, I start off with everybody in the sample here with PTSD. And what you see is two lines. The top line are people who we call high stressors. The low line people we call low stressors. What this shows you, the top line, are people who had symptoms far longer than people in the bottom line. But what was distinguishing the top line from the bottom line? It wasn't other traumas. What it was adversity of daily living. It was strife with spouse, challenges with kids in school, problems getting insurance to pay for your home, problems looking after your elderly loved ones. So these stressors intersect with the traumatic event experience and with the pathology to prolong the burden of symptoms in this population. And one can see this in many other studies. This, of course, is the quintessential lens that we do not take in clinical medicine and in many respects in public health. We tend not to think of financial troubles, relationship troubles, as kid troubles, as relevant to us as we study health. But this graph illustrates it quite clearly that if we care about improving population health, we need to understand that those social determinants are very much architecturally shaping the health of populations. They are providing the scaffolding on which pathology persists. And to make this point perhaps more starkly, I go back to another series of traumatic events. This was in the second Al-Aqsa Intifada in Israel. So we did a series of studies there, and it seems perhaps apposite to talk about it right now, given the threat of yet another flare-up of conflict. And I'm going to show you data now from a study that focused explicitly on the pre-1967 borders of Israel. We did other studies that focus on the post-1967 borders, and I'm choosing my words very carefully here because we looked specifically in the study at citizens of Israel. So we are removing from the sample, the large group of Palestinians in the region, in the post-1967 borders and even the pre-1967 borders, who have a lot of challenges politically with the system. So I'm leaving that aside. I'm focusing only on citizens of Israel. But within citizens of Israel, there remain two groups. There are Jews and there are Arabs. So with the Al-Aqsa Intifada, we looked at a representative sample of citizens of Israel, Jews and Arabs, to look at the burden of PTSD, depression, other psychopathology in this group. And what you find is that the prevalence of PTSD is 3 times higher among Arabs than it was among Jews within the pre-1967 borders of Israel. We tried very hard to explain this. And in a series of models, what you see here is from the left to the right, we're trying to explain this burden away. And what you have here is we're able to achieve about a 40% reduction going to the right bar, but the right bar still shows that Arabs still have about 90% greater likelihood of PTSD than the Jews. And if you look at the bottom, you see what we took into account. We took into account sex, age, income, education, religiosity, direct exposure, threat from conflict, economic loss, psychosocial loss, traumatic growth, post-social support, which is essentially everything that we know in the literature might explain the risk of PTSD. And we still have about a 90% greater burden among Arabs than we have among Jews. And our explanation, if you look at the papers on this, is that we are capturing here two populations who are faced with dramatically different burdens of social adversity. And this burden of social adversity is very difficult to capture in the using the methods of epidemiologic science. That no matter what we do, we could not fully explain it because you have two groups, both affected by traumatic events. But one group having this tremendous burden of social adversity, and when the traumatic event happens, that group is doing much worse than the other group. And that is what we're seeing here pretty starkly. And before I move on from post-event, I just want to make a comment about media. It's a question I typically get. This is from a study done by others, not by our group. This actually looks at television watching hours after September 11th. And the only point I want to make here is that people watch a lot of television. And you have about half the people in the sample said they were watching 8+ hours of television a day after September 11th. That's a lot of TV. But this is from a recent study that came out after the Boston Marathon bombings 2 years ago. And looking at the x-axis, number of hours of media-related exposure and then acute stress on the y-axis. And there are several more studies that actually show that media exposure is associated with psychopathology. It's a messy literature because of reverse causality issues, which I'm happy to talk about afterwards. But The reason I'm mentioning it is because, well, A, I frequently get the question when I talk about these topics, and B, as in an increasingly digital, interconnected world, the experiencing of large-scale traumatic events through digital media is going to become an ever realer experience. And we collectively need to get our hands on whether this is making things worse. And now my penultimate point on this is the environment. So I've talked to you about pre-event characteristics of the individual, the event itself, and post-event characteristics of the individual. What I haven't talked about is the environment. That we are increasingly recognizing that the environment in which the individual dwells is in and of itself determinative of the pathology and individual experiences after traumatic events, separate and apart from individual characteristics. To make this point, this is after Hurricane Katrina again. And what you have is on the y-axis is, on the y-axis you have depression. On the x-axis you have social cohesion. So this is a characteristic of the group. What you see on the right is low social cohesion, on the left is high social cohesion. And the dark bar are people who are displaced after Katrina, the light bar are people who are not displaced. What you see is that the people who did worse in terms of depression are those who were displaced and who lived in an area with low social cohesion. Interestingly, bottom right, those who were not displaced and low cohesion are fine. Those who were also displaced with high social cohesion also had lower likelihood of depression. So this is a characteristic that is outside of the individual. To go to a different set of events, these were the most expensive hurricanes in the United States before Hurricane Katrina. They were Hurricanes Jean, Ivan, Charlie, and Francis. They affected Florida, 2004. You're all thinking, I don't remember those. And the reason you don't remember them is because they happened in 2004 in Florida, right before the US federal elections, and they resulted in the most efficient federal government cleanup of anything ever, and they were all dealt with very, very quickly. That was, of course, before Katrina, which gave the government tremendous overconfidence about what they could do after hurricanes. We did a study looking at these counties that were most affected by these hurricanes. And what I want to show you is a classic epidemiologic interaction where we are looking at a characteristic of these counties and crossed with a particular genotype. In this case, the serotonin transporter gene, which is probably the best documented gene that is associated with psychopathology. And what you see here is this crossover pattern that in the diamond line, which is counties with high crime rate, so these are counties characterized by adversity, and the square line, which is low crime rate counties. On the far right, which is the short alleles, the counties with a bad environment where it had more risk of PTSD than counties with a good environment, while in the long allele, counties with a good environment had higher risk of PTSD than counties with a bad environment. This suggests a sensitization pattern, that this is a genotype that is associated with risk sensitization, and that interacts with a characteristic of the environment to produce the health of populations. And I'm using this example, I could show you many other examples of this, because it starkly illustrates that not only is it not just about the individual, not only is it not just about the individual traumatic event experience, or the individual's life before or life after the trauma, it is also about the environment, and it is all of those together that come together to produce the change in population health that we see after traumatic events. And to go back to New York City, this is income in New York City by neighborhood. New York City is a very heterogeneous city by income. You have, just to focus on two neighborhoods, the Upper West Side and the South Bronx, they're about 2.5 miles apart, and they have a median income about threefold difference. And in New York City, we showed that after September 11th, the odds of depression were about 100% higher among those who lived in low-income neighborhoods than those who lived in high-income neighborhoods. But here's the part that's important. That was independent of the income of the individual herself. Right? So you are dealing with two individuals, two women, same age, same color, same height, in two different neighborhoods. One lives in a neighborhood characterized by adversity, one lives in not. The one in the bad neighborhood is about 120% more likely to have psychopathology than one in the good neighborhood. Okay, so overall, the big picture, and then I'll wind down. So the big picture, let me put a number of studies together. You have now on the x-axis a number of the studies I've talked about. It's New York City, then Madrid, then Israel. And the blue bars are PTSD, the red bars are depression. And so these are all data I've already shown you, but I just want to draw some inference, some high-level inference from all of this. If you look at that bar, you'll see that most of these bars that I'm showing you here fall in that range. And most of this bar range is about 7.5 to 12.5, 15%. So the prevalence of Psychopathology after traumatic events in most groups is in the 7 to 15% range. But the exceptions are as illustrative as is the norm. So if you start off with Madrid, you see that the blue bar is quite a bit lower. Blue bar is PTSD. And the reason that's lower is because this was not a highly visible event. So as a result, the residents of Madrid had little direct exposure and PTSD was lower. Notice how depression is the same. Residents of Alcalá, which are people who are related to people with the traumatic events, the same. Very high prevalence among those injured. That's the next set of bars in both PTSD and depression. Low prevalence in police in Madrid, which as I said was a selection effect. Jews in Israel, roughly the same bar. Higher prevalence of both PTSD and depression among Arabs in Israel, which corresponds, in our assessment, with a greater burden of adversity faced by that group. Okay, so let me come back to populations now. And coming back to the health of populations and thinking through how this affects people broadly. So this is a population. I'm back to my blue paradigm. And the red are people who are exposed to something. So in this case, people who are exposed to a traumatic event. As I showed you earlier, a certain number of people will get pathology. I have the X's on the red, X's on blue, right? There are some people who are directly affected have pathology, some people who are less directly affected also have pathology, and those are the X's. So what do we typically do in the biomedical enterprise, certainly in high-income countries today? Well, our typical approach, to go back to the canonical public health thinking, is as follows. We say, let's say on the x-axis you have traumatic events, or experience of trauma, or intensity of trauma, whatever you want to say it is. On the y-axis you have number of people. As with most other things, it's a bell shape that most people are somewhere in the middle. There's some who are extreme on the right, some who are extreme on the left, which is less of the exposure. And what we typically do is we say, we have a high index of suspicion for pathology for people who have a particular burden of traumatic event. And we come up with a threshold and we intervene. So we say, look, if you saw the buildings collapse or if you lost a child in the earthquake, you are at risk. So we are going to do something to you. And by doing that, we aim, of course, to get rid of the risk in that group. That is essentially our entire biomedical paradigm. What is the problem with that paradigm? The problem with that paradigm is that we are dealing with the high-risk individuals, which is the red individuals, but we are forgetting all the low-risk individuals who also have pathology, all the blue people with excess. The alternate paradigm is you take the population and you shift the risk burden altogether, which is you lower the influence that a particular traumatic event can have on a population. And how do you do that? You do that by attending to the complex of factors, pre-event, post-event, environmental community that exacerbate the influence of a traumatic event. And by doing that, you of course shift the curve. And shifting the curve, you are still dealing with people to the right of the dotted line, and you are making sure you improve the health of everybody else. So schematically, if you have a population like this, the population health strategy has this population. We reduce the number of red people, and as a result, we reduce the number of X's. So just concluding, this was a bit of a run through a body of literature that really has flourished in the past decade. And I just want to conclude by highlighting what we do not know. And I'm going to do that just in 2 slides. And really, the message here is about the opacity of knowledge in a truly global context. That much of the science really has come from a few select high-income countries when probably that should not be our focus. This is from a review paper we did about behavioral health consequences of trauma. And what was, I thought, interesting about this paper, and credit for that goes to Charlie DiMaggio, a good colleague, is this map. And what you have here are black bars and gray bars. The black bars are where traumatic events happen in the world, and the gray bars is the number of studies on those traumatic events. So you see a very high concordance between those perspicacious scientists and where the events actually were. I mean, really, obviously, this illustrates that we are studying the events that we want to study and ignoring many events that we don't want to or cannot study. It's classic lamppost bias. So we know a lot about relatively few events, most of those events in high-income countries. And in fact, of course, if you look at traumas worldwide. This is the number of war deaths. In the past decade hasn't really changed if you look at it right now. And if you look at other burden of traumatic event, it is indeed most pronounced in low-income countries, principally Africa, as well as Southeast Asia. So a fuller understanding of the burden of traumatic events in populations would need to take a global lens and expand what we know quite a bit by looking at the entire health of global populations. I'll stop there. I'd be delighted to take questions. Thank you.
We have time for a few questions. Sandro, maybe I'll start. You talked at one point about interventions.
Yeah.
Do we know anything about PTSD, in particular population-level interventions for large-scale traumas?
Yeah, so we actually know quite a bit. We know quite a bit about both pharmacotherapy as well as manualized cognitive behavioral therapy approaches that make a difference for burden of PTSD in populations. But perhaps the most important message is that from a population health lens, the interventions that can truly reduce the burden of population pathology are atypical of interventions that you might label as PTSD interventions. So I am here to say that an intervention that lifts the risk of having poor housing after a traumatic event is a health intervention. And that is a shift in our thinking that we have not been able to affect. I realize that there's an intimidation factor of the large lecture hall. Yes, very good. Somebody rides beyond that.
That was an excellent presentation, a really nice introduction to an area that I don't know much about.
Thank you.
But could you talk a little bit about the measurement of PTSD?
Sure. Yeah, so there are standardized instruments for measuring all psychopathology. They're validated cross-culturally. There are books about the challenges of cross-cultural validation and whether or not that is valid. There are also arguments about whether or not psychopathology really is valid to begin with and what these categorical constructs means versus dimensional constructs. Make a long story short, everything I showed you elides that question altogether. We did stuff using state-of-the-science measures, but there is a very interesting and rich set of discussions about the nature of psychopathology, what it means to have psychopathology in different cultural contexts, as, by the way, there should be similar discussion around much of what we typically call physical pathology. We tend to forget that a lot of what we call physical pathology is ultimately predicated on relatively arbitrary categorical cut points that we have come to accept. Things like arthritis and many low mortality chronic conditions. They are very much constructs of a way in which we pathologize health, as is mental health. So it's an interesting question and one that bedevils the entire field. Yes, ma'am.
So, and I think I've heard currently from people who have lived experience with trauma is that there's somehow a protective effect from belonging to a community or a country that where everyone has also experienced civil war, for example. I was wondering if you could speak to that.
Yeah, that probably would fall under the slide where I showed you about social cohesion. So if you were to have a counterfactual, if you are to have a population that is exposed to a large-scale traumatic event, and the population is fragmented, there are inter-individual animosities, and there's no cohesion in that group is going to do worse than a group where there is social cohesion. So I do think there is a protective effect of community. Those were some of the slides that I was showing. And of course, it's very difficult to tease that apart. It's very difficult to experimentally manipulate these factors, but I've become convinced that group-level social cohesion, group-level social capital is among the best protective factors that we can come up with. We've actually done some work among soldiers and looking at, sort of making this case, right, about pre-event, the event, and post-event, trying to quantify, so if one were to intervene somewhere, where could you achieve the greatest benefit? And in soldiers present an interesting case study because you know exactly when they went, when the trauma happened, like it's pretty well documented. It's probably social cohesion of the group that receives them, where you can make the biggest benefit. Unfortunately, in the context of soldiers, particularly of reservists, which is a group that we study quite a bit, they're frequently discharged from active duty, and then all of a sudden they're left to the wolves. But if one were to intervene, looking empirically, that is probably where you can intervene and make the biggest difference. Not the pre-event, not the event itself, but post-event social cohesion.
So maybe we'll have one more quick question because we are over time.
Yes.
So you spoke about resilience and resistance a little bit. I was wondering if you could speak a little bit more about post-traumatic growth, which has been spoken a little bit in relation to
Yeah.
that, and what kinds of population health strategies could probably promote that.
Yeah. I was afraid you'd ask that. Because I'm deeply skeptical of post-traumatic growth. I am not sure it exists. I think I'm not sure it exists in the context of health. I think there is a literature that emerged from psychology that said you have a traumatic event and you change your life in positive ways. I'm not disputing that, but I have not seen any evidence that post-traumatic growth, even as measured by those indices that say you change your life in positive ways, is associated with better health. And something which we can debate. We've actually published this in literature, so I'm not saying anything that I haven't said publicly. And I suppose there is a question, well, what are the dimensions of living that one values? Maybe it's not just health. There are other dimensions of living. That may well be the case. But on the axis of health, I do not think that trauma is ever good. I think it is a negative. And some people do better, some people do worse for a variety of reasons. But the more trauma you have, the worse it is. And there's pretty compelling evidence from the Great Smoky Mountains study that with enough traumas people experience, everybody eventually has pathology, either mental or physical, with enough trauma.
So I'm going to have to call to an end because we are over time. But thank you very much, Sandro, for a very stimulating talk. And maybe people can come in quickly and ask one or two questions if they have time.
Thank you very much.